Good morning and congratulations and thanks for the World Congress GI of ESMO for the invitation, and thanks Arndt and thanks Jordi for having me part of this exciting morning. So new agents, we heard quite a bit already, this few excellent presentations, and of course the sequence of therapy as well. I was tasked by talking about the role of TKIs, so by all means I will be biased towards TKIs, but I think it's a very genuine and valid bias over here, as we'll see. With this said, these are my contacts, if you'd like to take a picture or reach to me. And these are my disclosures. And this is what I'm going to talk about. We have quite a bit of TKIs, as you can see over here, and we'll start, of course, on top of the line with Sorafenib, which, if you recall, this was a game changer with the data of the SHARP study that led to the approval of Sorafenib pretty much all over the world, showing an improvement in survival 10.7 months versus 7.8 for placebo, and this became the first therapy that we kind of were tucked in for several years as the only choice of treatment. If anything, while it really gave us answers, it also provided several questions, among which, and you recall, there is no response that really can occur when it comes to the TKIs. The tumors don't necessarily shrink per se. Give credit here for our colleague Larry Schwartz, the chairman of radiology at Columbia now, together, and this is from our phase 2 data that preceded the phase 3, have shown that the tumors actually can have a quote-unquote tumor necrosis component as part of the response to Sorafenib. This is literally the CAT scan of the 5th patient to ever receive Sorafenib. And as we can see here, the tumor, which was a peritoneal deposit, biopsy proven, remained relatively in the same size, maybe increased a little bit, but the alpha-fetoprotein really improved by 5-folds, dropped by 5-folds, not showing here, and the necrosis, as you can see, dropped about 53%. This is kind of like an introduction to what we're going to see later on about the modified resistance. That's why I'm bringing it up over here. However, after 10 years of wait time, impressive work that Dr. Bruges led on Regorafenib, where a study for patients with prior exposure to Sorafenib but progressed on the Sorafenib were randomized to Regorafenib versus placebo, and again showed an improvement in survival, as you can see over here, 10.6 months for the Regorafenib versus 7.8 for the placebo. This actually led to the approval of the drug in several areas in the world as a second-line therapy with the conditional use of prior to Sorafenib per se. Add to this, one might wonder, because what we know about Regorafenib is a tyrosine kinase inhibitor with almost a similarity to the Sorafenib. Not necessarily true, because if anything, a certain resistance to the Sorafenib is led by the activation of IGF and FGF, which, if anything, are targets that the Regorafenib can attack per se. And this maybe was not part of the study. Nonetheless, it's a theoretical component that can exemplify why patients who truly progress on Sorafenib will respond to the Regorafenib. And this is further explained and impressively seen in the nice word from Dr. Finn, whom we just heard from in regard to another study, but this is nice work that looked at the exploratory retrospective look of patients with prior Sorafenib followed by Regorafenib, median survival for the whole process from the start of Sorafenib till the end of the Regorafenib and death. And as you can see over here, having a survival close to about the 26 months is not something that we have heard of because beforehand for TKIs. I would urge you to keep those numbers in mind when we come to the understanding about the checkpoint inhibitors a little bit later on. Lenvatinib came, I would say, from the left field, but rather quite impressive, another TKI, as you can see here, with multiple targets, with probably a high focus on the FGF component of the work. And if anything, the plan was for a non-inferiority study i.e. we're trying in that study simply to see if Lenvatinib is as good as Sorafenib. Please, it's very important to make sure that we really read it that way and understand the question that way. And the study as such was positive. If anything, we can see over here, Lenvatinib improvement in survival 13.6 months and Sorafenib 12.3. And again, this is within the context of the non-inferiority was a positive study. On top of that, though, if you recall, I spoke a little bit about how we might dissect some of the responses from the Sorafenib per se. Well, Lenvatinib rather did quite impressive in that regard, actually represented by PFS, as you can see here, that almost more than doubled, close to tripled between Lenvatinib in favor compared to the Sorafenib, which again was represented by the response rates that by the RECIST criteria 1.1 were about 25%, and by modified RECIST talk about that necrosis component close to about or more than 40%. And these are nicely represented over here as well. And this, for the first time, bringing to us that TKIs like Lenvatinib can truly improve on the response rate. Cabozantinib is another TKI that, if anything, was as nicely presented a little bit earlier by Dr. Miksad, was shown to improve survival, as we can see here in second line, Cabozantinib versus placebo, 10.2 months versus 8 months, and again, statistically and clinically significant, and led to the approval of the drug in the US FDA and other entities. We proudly presented this in the New England Journal of Medicine, and if anything, the difference in regard to the Cabozantinib prior to other TKIs of the c-Met inhibition being Devantinib is rather intriguing, because Devantinib is another c-Met inhibitor that, however, in the same kind of design study versus placebo was negative. If anything, the phase 2 data and the investigators at that time for the Devantinib argued that patients with the high c-Met expression, which was defined as a 3 to 4, 50% or more expression or immunostain of c-Met, will probably don't do that well without therapy, as we can see here with the median survival of 3.8 months versus the low c-Met 9 months. And as such, maybe best is to treat the patients with the high c-Met with the Devantinib. Maybe they were right, but we argued the other way around, because for us, we felt like even a whiff of the c-Met activation will not necessarily be a refusal for benefit to the Cabozantinib, understandably, because the therapy is a multi-TKI and not Cabozantinib antibody specific. And this is what was nicely presented at ASCO, where we have shown that the benefit will definitely be there. And not only that, but again, side effects might drive a benefit in regard to the outcome, as you can see here from the pulmonary erythema as well as the hypertension, which again, an important reminder when it comes to the IOs, that sometimes side effects, we don't wish them, but they could be beneficial for the advancement of a response. With this said, we came to Ramucirumab. And again, Ramucirumab is a anti-VEGF TKI. If anything, the study that was done as REACH2, a follow-up to the REACH study that focused only on patients with high alpha-fetoprotein, did show an improvement in survival, 8.5 months for Ramucirumab versus placebo 7.3. Again, clinically and statistically significant. I would say that we're still not in full understanding of what does the high alpha-fetoprotein means, and expectingly patients with different risk factors might have different high alpha-fetoprotein, i.e. a hepatitis B related HCC will have a higher alpha-fetoprotein than a hepatitis C. But on the other hand, a prognostic component of the alpha-fetoprotein is probably at least exemplified in this study that we will see how further this might be analyzed. And to that extent, we have seen at ASCO a combination of the REACH study, which was the one without a clear classification of the patients with the high alpha-fetoprotein, but there was a prospective analysis, and this combination of the prospective analysis look of the high alpha-fetoprotein patients from the REACH study and the REACH2 were joined together, and as you can see, the survival improved enough to join with the other checkpoint TKIs correction, like in the 10-month range. So as you can see here, plenty of data. It's all positive. 5 drugs that really crossed the line and really provided our patients with opportunities. But of course, still today, all of us, or many of us, our patients will ask about the checkpoint inhibitors. So what to make out of the TKI versus IOs? I would say that everybody is trying to line up things. You might recall I showed a picture like this last year, and this is how complex it is. I have to say jokingly that we ran out of colors over here because of the different scenarios. But I would say this is a little bit now more simplified, as you can see over here, because Sorafenib and Lenvatinib are definitely steadily in first-line setting, TKIs. In regard to second setting, we have Regorafenib followed Sorafenib. We have Cabo or Regorafenib. We have then the 2 checkpoint inhibitors being Nevo and Pembrolizumab, and we have the Ramucirumab for the high alpha-fetoprotein. And then, of course, in regard to third line, the question is, where do we place the checkpoint inhibitor? Do we kind of like be very particular about putting it in second line just because we are really eager to give it to the patients? Or will it matter that prior exposure to TKIs will benefit more from the checkpoint inhibitors? This is yet to be proven per se. I, however, 100% agree with what Dr. Bruce just mentioned. The data on the Pembro and Nevo, we can read it any way you want, but at the end of the day, Dr. Bruce is right. This is negative data. And if anything, rather than try to see which subgroup and how the statistics were planned, etc., because remember, when we design a study, we really design the study with a certain aim. If we don't meet that goal, it means the study is negative. And for that reason, I would say there is a lot of effort that is to be followed in regard to the combination therapies, because clearly the checkpoint inhibitors are not proving it by itself. And if anything, here is only one example. There are many others, but this is the Atezo plus Bev. This is data that quite a bit many of us were excited about. That was presented 2 years ago at ASCO and then repeated at ESMO last year. And if anything, there is a lot of intriguing component about the combination of the anti-PD-1 or anti-PD-L1 plus a anti-VEGF, as we can see over here with the spot that we can see to the right of the slide around point number 5, where the VEGF can really activate the immune pathways, and as such, probably the combination is right. On the other hand, the other thing which is important from this picture is to remember that the checkpoint inhibitors are also of different flavors and they can work differently. And the same thing, we can attack the tumors at the tumor level, being with the anti-PD-1, anti-PD-L1. Upstairs in the lymph nodes, there's quite a bit of action ongoing, which probably the anti-CTLA-4 will come into play. And this is really what the Himalaya study will help us define what is the role of the Durvalumab as an anti-PD-L1 plus Tremelimumab as an anti-CTLA-4 versus, again, a standard of care TKI. With this said, I would conclude that Sorafenib and Lenvatinib are approved first line of therapy. Regorafenib, Cabozantinib, Ramucirumab are approved second line of therapy. That's a lot of approval for TKIs, and checkpoint inhibitors so far have not shown the overall survival improvement in first or second line therapy. Thank you very much for listening.